So very good afternoon to all. Again with the case of complex high rectal fistula. You can see I will explain this fistulogram. This is a patient from Ambedkar Nagar, Uttar Pradesh. This patient is having pus discharge and plus and blood discharge from the perianal area with a bowel which is approximate 6 centimeter away from the anal verge. So that is the presentation of that fistulous tract, and this fistulous tract I will show you in fistulogram clearly first. Then there are two views of these this fistulogram. One is AP view and one is a lateral view. So very clear and very good fistulogram it is basically. So you can see the catheters in both the films again, and this is a plain catheter which reaches up to the near the sacroiliac joint. You can clearly see, and there is a presence of dye in this film. You can clearly see. This is the urographene 75 which is injected from the external opening of this catheter inside, and you can see there is a tract basically. There is a curvilinear fibrosed tract, you can clearly see, and it attains the half horseshoe shaped fistula basically. So again with this picture again you can clearly see this is the presentation, and very interesting in lateral view. Very interested in lateral view. You can see both the films of in lateral view. This is the sacral bone you can see, and this is the rectum. This is a whole rectum. This is a pre-sacral fascia behind this, you can clearly see, and this is the lower part of the rectum, and this is the catheter. You can see the dye is injected from this area, and it reaches up to the nearby lower part of the rectum by crossing the anorectal junction. So this is a case of transventric. This is a case of transventric high rectal fistula with the prominence. You can clearly see this fistulous tract. A beautiful surgical procedure which is invented at Patanjali Ayurveda Hospital by the surgery department. So this is nothing but a modified technique what I am using for lift. Lift is basically different from this technique, because in lift technique we have to ligate all from both the two branches, that is both branches we have to ligate, but I do not ligate first. First what I will do is I will do the DLPL followed by dissection, because with DLPL there is a narrowing of the cavity, and when I approach through this intersphincteric space, and the tract is very much clear, and the sphincter the anatomy of the sphincter is very much clear there. So that then from DLPL with window with fixation followed by Shara Karma and Shara Sutra ligation is the prime therapy nowadays for fistula and nano treatment. So this is Dr. Sachin Gupta, Patanjali YOGPEETH, Haridwar. Thank you.